pandemic that we've gone through has really saved lives on many aspects of that, including the quality of care and equal access to care. There, to be honest, we had a discussion with our two panelists maybe a week and a half ago, and there are many conversations that we're having, and there are many conversations still that need to be started so that we can actually have them in a robust way. But today we're going to talk about, in particular, algorithmic fairness. That's a topic that is near and dear to me in particular. We're going to focus specifically on triage algorithms. So this is specifically about healthcare, and then see the important role that ethics have to play in that. We will hear from two experts. And these two individuals are Carri Chan, my good friend, colleague from the Decision Risk and Operations Division at the business school, and until about 2 years ago, my office neighbor, and Dr. Katherine Fischkoff, who comes from our Uptown campus, our medical campus. So she is an acute care surgeon and intensivist, but she's also an ethics consultant. So she sort of thinks about these questions acutely. I'm going to use that word twice at our Columbia University Irving Medical Center. And these two individuals came together through their work in healthcare and also through their connection to something that we have started at the university called Columbia World Projects, which is an initiative to sort of bring the force of the university to sort of address important problems that our society and our community is grappling with, both in our own backyard, but also globally, hence the name. So both of them were involved in this sort of issue about data, algorithms, ethics, and how we've been sort of talking about how to collaboratively. Our plan for today is the following. First, Carri is going to present some research on ICUs, in particular ICU care and the management of resources in these sort of congested environments during the early days of COVID, where you had to make prioritization decisions about how to use the few resources you have. And then Katherine will provide her overview of Columbia's hospital response to the pandemic, which was amazing, and discuss different models of triage. After these short presentations, the three of us will have a short conversation. I'll try to keep myself out of the discussion and have the experts share their comments, and then I will moderate discussions with the questions that each of you will provide. So without, as an introduction, I would like to turn the floor to you, Carri.
Thank you, Kostis, and thanks all of you for being here. So today I wanted to talk about some of the research I had been doing pre-pandemic, and then how it kind of evolved over the last 16 months. And so I want to start off by kind of giving you a perspective on where the state of healthcare delivery was pre-pandemic. We knew that in that March timeframe, when there was questions about lockdowns and how to go about them, there were concerns about ICUs specifically getting overwhelmed. So I want to just start by giving you a little bit of a sense of what the state of ICUs are in the United States, even in non-pandemic times. So why are ICUs so important? And I'm sure Katherine can talk more specifically about the clinical aspects. But if we think about the hospital setting, ICUs provide the highest level of care for patients. These are for the most unstable patients. They often need one-to-one nurse-to-patient care. In some states, and within Massachusetts, there were questions about whether or not regulations were able to dictate what those ratios were. But for instance, in California, it's mandated that a single nurse in the ICU can't treat more than 2 patients. That's the requirement there. Patients who end up in the ICU have incredibly high mortality rates. Now, we think about the state of the number of ICU beds, they actually take up a smaller portion of the total number of hospital beds, but they clearly have a really critical role, and they consume an exorbitant amount of money, in large part because of the equipment that's required, and primarily the high staffing requirements, the specialty of the staff that's treating the patients. Now, in non-pandemic times, the average occupancy in ICUs across the country is about 68.2%. But there's a lot of fluctuations around that. And so there's certainly times when the occupancy in the ICU starts to hit capacity. There's also substantial heterogeneity across different types of hospitals. So if you look at federal hospitals, surgical ICUs, and large hospitals, these average ICU occupancies are much higher, meaning that even in non-pandemic times, hospitals are operating with a very, very limited slack, so that when there are large increases of patients, this happens during flu season, for example, these units can get very, very strained. And so certainly when a worldwide pandemic hits, it becomes a big, big challenge. So from some of the work that I've been doing with various hospitals, I want to just give you a sense of how much variation there is. And so by looking at just averages, it really doesn't paint the full picture. So this is data from the Kaiser Permanente healthcare system in Northern California. And so these in blue are the bars of the number of ICU beds at each of the hospitals. And then the pink line shows the average ICU occupancy. So you can even see within a single healthcare system, you would expect that there may be more commonality, but there's still already a lot of variation. And so this, you know, we expand out to the world, this is a big issue. So why should we be so concerned? As long as there are beds available, do we need to really be concerned about occupancy? Is it really only once you hit that capacity limit that it's an issue? And it turns out that it becomes an issue because of the way that patients, they end up staying in the units for a long amount of time. So decisions that you make for a current patient today actually impact the decisions you're even able to make in the future. So here's some data from some of the research projects I've done in the past. And it's split by different severity groups, with 20 being the most severe patients and 1 being the lowest severity. And these are of the patients arriving to the hospital, what percentage of them are being admitted into the ICU? And now I have two curves. In blue is what happens when there's ample ICU capacity. Right, so this is, there's multiple beds available, you know, at least 2 or 3 beds available. What percentage of patients are being admitted into the ICU? Now, not surprisingly, the more severe patients, a larger proportion are being admitted into the ICU. That is what should happen. But when the ICU starts to get busy, but this is not when it's full, when there's only 1 or 2 beds available, we see a substantial drop and the percentage of patients that are being admitted. And this is because, again, the decisions you make for a current patient today impact your ability to treat other patients in the future. And so, you know, inadvertently, there are decisions that are being made of when the ICU is busy, who is supposed to be able to get that last bed or that second to last bed. And those are a lot of challenging questions to try to grapple with. The biggest concern about this is not just that you don't get access to care, but that lack of access to care, not surprisingly, is associated with worse outcomes. So again, using data, we estimated the impact of patients comparing those outcomes that they would have had if they were able to get ICU access versus the case where they weren't able to get admission into the ICU because of these capacity issues. only because of the capacity issues, not because, there's certainly patients, their severity is very limited. They don't actually need to go in the ICU. It's the difference between going to the ICU versus not going to the ICU because of capacity limitations. And we see that there's a substantial impact. Now, we didn't see a statistical significant effect on mortality risk, in part because I think clinicians are actually pretty well trained to be able to understand if this decision is going to impact someone's mortality risk, that, to avoid that. But we found that there were kind of longer term repercussions that maybe aren't as obvious and aren't as severe of an outcome as mortality, but no less important, right? So we saw that patients who were not able to get into the ICU, they had an increased risk of deteriorating and having to go to the ICU later. They had an increased risk of being readmitted to the hospital after discharge. So after we thought that they had stabilized enough to go home, they actually have to come back. And their length of stay increased by almost 2 days. And so we're using up these limited resources even more so in these types of capacity constrained situations. Even if the patients are able to get into the ICU. So the ICU is congested, maybe they're waiting and eventually someone gets better and they're able to get in eventually. What is the impact of that delay? Well, patients, if they're not getting that high level of care that's required, they can deteriorate while they wait. And so we found that once they eventually get into the unit, into the ICU, their length of stay actually increased. And depending on the primary condition of the patient, that increase could vary from about 10% to 38%. Again, we are essentially shooting ourselves in the foot. We are capacity constrained. Because of that, we can't get people in, but then they actually end up needing that resource even more so. And so we have to really think about managing these resources in a very careful way. So, I've spent a lot of time trying to understand what is the impact of congestion on the patient outcomes. And there's various things that can occur. As I mentioned, some patients may wait to get into the ICU. They may get admitted to a lower level of care, or you may even have a patient who is in the ICU who is less severe, who is moved down to a lower level of care to accommodate that more severe patient. And so it turns out that there's actually, limited criteria, like data-driven criteria about when to use these types of decisions. What is the impact of these types of decisions? There are guidelines that say, do the limited, minimize the amount of harm. The sickest patients should be admitted. But how do you define that? There's a lot of gray area. And so that's where a lot of my work had focused and has focused over the years, is using models and analytics to guide these types of decisions. Using a bunch of tools from mathematical modeling, statistical analysis to help guide these particular decisions. And so what do we gain by taking this approach? Our models allow us to really understand what are the core trade-offs when making these decisions. And we can actually make counterfactual analysis to say what would happen if we increased bed capacity, or if we admitted this patient versus this patient, without necessarily running a randomized controlled trial, which can be very challenging, certainly from an ethical standpoint. Here, you can't randomize admitting someone to the ICU versus not. And so we can try to explore through these models what that impact may be. It's a really exciting area to be in right now. The availability of data is continuing to grow. Even New York Presbyterian now is in the process of transferring all of its hospitals to the same electronic medical record system. And so you're going to see that there's more comprehensiveness, more integration. And so there's a lot of opportunities to guide these types of decisions. So I wanted to take just a little bit of time to discuss how this kind of research agenda played out during the COVID pandemic. And one of the projects that I've been working on, incidentally with colleagues at the Montefiore Medical Center up in the Bronx, is to try to understand ventilator allocation. And there were fears that there would have to be really tough decisions about who would get a ventilator versus who would not, as we saw it happening in Italy, and as there are other countries like India and Brazil right now are grappling with. And so there's actually a official triage algorithm that New York State has put into place, and it was put in place in 2013, so before COVID was even known. And you can actually split it into what we look at as a tree policy. So you can think of it as a decision tree. You look at the severity of the patient, and so the SOFA score is a severity score about the patients. And if the patients are actually very, very sick, unlikely to benefit, their priority level goes down. If they're kind of moderate and likely to benefit from getting that ventilator, they're going to have that highest priority. And so the way that the New York State policy works is that you give ventilators to patients as they need it until you hit that capacity constraint, and then you follow this triage algorithm. So what we wanted to do was understand what would happen in the event of a shortage. Thankfully in New York, the triage algorithm never had to be implemented through procurement of ventilators, through people donating, other states donating or lending their ventilators. It was never needed to be used. But this begs the question, if you had to use the algorithm, would it have been effective? Can we actually do better? And so I want to get into a brief discussion of that. So we did some statistical analysis, and the two curves here are looking at number of deaths depending on what the ventilator capacity would have been. And the blue curve is the New York State policy, and red is first come, first serve. So first come and first serve, you could almost think of it as I don't know, random luck based on when someone showed up at the hospital. Did they happen to show up before did patient A show up before patient B? Really, there's nothing else distinguishing them. And you can see that the curves are basically indistinguishable. And so one of the reasons that the clinicians that we've been working with suggest is that likely this triage algorithm was not designed with COVID-19 in mind. And so there are certainly potential opportunities for improvement. So what we're working on now with a PhD student and a colleague of mine in engineering is trying to develop a better triage algorithm. So this is an example of a potential triage algorithm. It looks at the severity of the patient. And then we know that factors like BMI and liver disease may make people more predispositioned to having bad outcomes. Now, this tree is an example of if we designed a triage algorithm to maximize lives saved. But in talking with Katherine and talking with other clinical ethicists, considering factors like BMI, we know that that's a big risk factor. But this ignores kind of the systematic limitations of health access that many communities have faced over decades, centuries, that have made them potentially more predispositioned to having these risk factors, and that having a triage algorithm that kind of blindly just tries to maximize lives saved may end up, unfairly, impacting underserved communities. And so we have to think about how to integrate these implications into our data analytics. Does it mean that we don't allow the machine learning algorithms to utilize these features? Does it mean that we manually tweak them? And these are really challenging questions that I don't think we know the answers to, but it's so important to keep in the back of their mind. So I just want to quickly wrap up before I hand it over to Katherine. I just want to highlight that even in non-pandemic times, there's very limited slack. And so, we've seen even pre-pandemic that due to variability, this mismatch between supply and demand can really impact access to care and outcomes. Using models and analytics can help us make these types of decisions and understand and how to do them better. But these ethical considerations are clearly very complex, but are so essential to incorporate. So with that, thank you for your time. I want to pass it off to Katherine because I think that she has a lot of interesting perspective on these tensions that we're discussing. So thank you.
Terry, that was fabulous. I'm going to pull up my, it's so great what you can share, the pictures that you can paint with numbers. And I'm really happy to be here to give you some other perspective on this. I'm going to start with just briefly talking about a quick overview of hospital capacity, definitions of capacity, and how we know when we get into scarce resources. Hospital capacity is typically defined as a spectrum from conventional capacity, contingency capacity, and crisis capacity. So conventional capacity is where we are in normal working days, where the space and staff and supplies, the supply of those are equal to or greater than the demand, usually by not a whole lot, as Carrie said, but we're doing okay. Contingency capacity is when you start to get full and you start to change your practice a little bit, but without impacting patient outcomes. And so actually we're often in contingency capacity, right? That's when, for example, there's not an ICU bed immediately available for a post-operative patient and they have to sit in the recovery room overnight while they're waiting for a bed. And so patients are housed in atypical spaces and perhaps being cared for by atypical staff, but they're not harmed. But of course, as you move into crisis capacity, we are starting to make substantial changes to how we provide care. And there are significant impacts and implications for patient outcomes. So in crisis capacity, there's not enough space, staff, or supplies. And so, for example, staff are practicing outside their normal areas of expertise. Supplies are reused and recycled. And in some circumstances, resources may become completely exhausted. And so crisis capacity is sort of all about doing what you can with what you have. I would like to. I'm going to show you. This is a bed map. This is something that we developed early in the pandemic and in the first surge to try to create a visual overview of what the hospital looks like. And this is one from the very beginning of the spring. You can see about a month into the pandemic. And so a couple of things to know about this here. Each color, but this is just part of the hospital, but each colored box here represents a bed that is filled. And what is notable is that red represents COVID positive patients and green are COVID negative patients. And you can see that the hospital was overwhelmingly COVID. The second thing that I want to highlight, if you look across the top row, that represents our typical ICU. So you'll see medical ICU, surgical ICU, neurocritical care ICU, that kind of thing. But you will also see in that top row, the operating rooms. So early in March, Governor Cuomo announced that all elective surgeries were to be canceled. So we at Columbia kept 3 operating rooms open and the rest of the operating rooms were converted into ICUs. And this was done in a weekend. And I can't emphasize enough what a huge job this was. So besides repurposing the operating room space, we also had to staff it with non-critical care trained nursing and physicians. We used anesthesia, we used ventilators that were not our typical ventilators, as Carrie mentioned. This is crisis capacity. And then the other thing I want to show you up at the top, I don't know if you can see, it says that there are CCUs, the cardiac critical care units. Those typically have 10 patients available, but you'll notice that there are actually 20 patients filling the units. That's because those 2 ICUs are on our newer wing and so had a little more space. And so we were able to cram two patients per room. You'll also see in the second row that the emergency department had a pop-up ICU. We have a big sort of conference room Riverview that we converted to a pop-up ICU. And then the other thing that you'll see is that each normal ward floor, we stole four rooms from each floor and we converted them to 2 patient ICU beds. But to give you a sense of what crisis capacity means, when we converted those floor beds to ICU beds, so normally in the ICU, the walls are lined with glass and so you could see directly into the patient rooms. the beds and the floor are the doors are these big heavy wooden doors that obviously during COVID have to stay closed. And so there's no way to see into the rooms to actually see the patients to see that they're okay. And so the nurses would bring in their old baby monitors, and they would install the baby monitors in the room, and they would have their monitor part on the outside, and that's how they looked. That's how they monitored the patients. So that's crisis capacity. And then the last thing I want to point out, if you look at the top right, you'll see one ICU that is exclusively green. And this was a difficult decision that we made at the time, which was to maintain one unit as exclusively COVID negative. And you can see there's one empty bed at the bottom of that unit. And so you can imagine how controversial it was to have one available ICU bed that we were holding in the face of the hospital just bursting at the seams. But that's what we had decided to do. This is going to be, I'm going to show you this video, but I just want to draw your attention to two things. This is a moving graphical representation of our ICU capacity over time that was developed by Beth Hockman, one of my surgery and ICU partners. And if you look at the top, you'll see the date, and then red is COVID, green is non-COVID, and you will see how things unfolded over time. So this starts on March 25th. We're about a week into our ICU, into our first surge. And what you need to know is that our typical ICU capacity is 117 beds, but you could see how quickly we blew right through 117 beds. We were half full, initially half COVID, and then all COVID. And you could see as we get deeper into the spring, we more than doubled our ICU capacity. And then as we get into the summer, you could see here the surge is starting to ebb, and we're more or less back into normal operating capacity, and there's very little red at this time. And this is where we're all scrambling around trying to catch up on this backlog of operating room cases, for example, that we had left behind. But then you could see here as we get into fall and winter, this is now surge 2.0. And what you're going to start to see is that while the peak of red isn't actually that high, it doesn't budge. So that our ICU COVID census really just is stuck at a third. And so here we are trying to get back to normal operations, but a third of our ICU beds are full of COVID patients. And it's really also important to know that the length of stay of a COVID patient in the ICU is weeks to months as compared to days to a week or so for our typical patients. So as this runs down, I'll just say that, the goal of emergency disaster planning, of course, is to avoid getting into contingency and crisis capacity. So with careful planning, employing strategies of expansion and repurposing, substituting equipment, things like that. The idea is to try to avoid getting into crisis capacity and minimizing ICU strain and the impact on patients. But as you saw in that thing, we just blew right through contingency capacity into crisis capacity. And of course, when we enter crisis capacity and it's the strain on resources that you get, we enter something called crisis standards of care. And crisis standards of care is when a healthcare system is so overwhelmed by a catastrophic public health event that we can no longer provide the normal standard of care to patients that we do in normal times. And when something like that happens, we require legal and regulatory protections and guidance from state government to try to acknowledge that we are in crisis and that may last some time. And so you'll remember that on March 8th, Governor Cuomo declared a public state of public health emergency. And this was followed very quickly by a series of rules suspending the normal rules, for example, of credentialing people in hospitals so that we could get as many people into work as we could. We suspended all elective surgery. And then on March 25th, the governor passed the Emergency Disaster Treatment Protection Act. And this provided some immunity from civil and criminal liability to healthcare workers from any adverse outcomes that occurred during the care of patients during the pandemic, when, of course, in good faith. Now, this immunity applied to adverse events that happened in the normal course of caring for patients in a pandemic, but it did not give permission to triage, and that's a really important point. So the question is, why triage? So the goal of a triage plan is to impose planning and organization on an otherwise catastrophically chaotic situation. And we do this, and Carri showed this beautifully, we do this because modeling studies and studies on ICU strain show that in the chaos of trying to provide scarce resources to everybody, predictor mortality is actually worse than if we were able to focus our resources using a triage system. And so in normal practice, we follow this first come, first serve model, right, where you get cared for as you show up. But the problem with that kind of a first come, first serve model is that it leads to overall worse outcomes across a population and has more individuals being denied critical care access, and it exacerbates the already existing inequities in healthcare that allow some people to get access to care sooner than others. And so in the absence of a triage system that is consistently applied both within and between hospitals, you can lead to unnecessary deaths, increased moral distress of healthcare workers, and a lack of public confidence in the fairness of scarce resource allocation. So what are the ethical principles that underlie triage? First, we have to acknowledge that there are always competing ethical objections and obligations whenever you're dealing with a crisis and a pandemic. And these may be in conflict, but they have to be balanced, right? So for example, you want to minimize the number of deaths due to COVID, but we also need to balance that with public order and individual autonomy and ability to make decisions for yourself. And so similarly, a triage system has to carefully reprioritize our normal ethical principles that guide our care. So triage is a shift from our normal first come, first serve model to a more utilitarian approach in which we promote the good of the public over the good of an individual patient. So the ethical principles that we talk about when we're designing a triage system is our duty to care. And we have a duty to care to all patients, including patients who are not triaged to ICU level of care, right? They still get care to the best of our ability, and sometimes that means palliation. We have to prioritize the accountability and the consistency and the transparency of any system that we develop. And of course, we're obligated to build equity and fairness and non-discrimination into our triage system. So Carri started to talk about this, how does a triage system work? I mean, in a broad sense, patients who present to the hospital are going to fall into one of three categories. You're either too healthy, too well to benefit from critical care. You're not sick enough. You're too sick because of such severe underlying illness that you wouldn't benefit from critical care. And then there's that, sort of Goldilocks, just right, sick enough to benefit from critical care. And so a good triage system would have an excellent predictive ability to identify exactly those patients in that third category who are likely to survive the hospital stay if they're provided access to an ICU bed. And then, of course, the patients who are not offered an ICU bed are cared for to the best of our ability and continuously reassessed as beds become available and if it's clinically appropriate. I just want to make one really important point that we talk about a lot in ethics. So in the beginning of the spring, Carri had mentioned every hospital, every medical society, every state designed their own triage system. Many were based on the SOFA score that Carri had mentioned, but none of them were ever formally employed. But Carri mentioned the first phase of the New York State ventilator allocation guidelines, where certain patients would not meet criteria to get a bed. But there's actually a second phase of that guideline. And in that second phase, if resources remain scarce, patients who are already in the ICU on a ventilator, who are not meeting certain milestones, who are not progressing, get reassessed at intervals. And if you aren't meeting certain milestones, we actually take you off of the ventilator, or proposed, the patient is taken off the ventilator, care is withdrawn, and those resources are allocated to somebody else who is deemed more likely to survive. But this is a really, really, really important point. There is a huge difference between withholding therapy, such as admission to an ICU, and it's a wildly different thing to actively withdraw therapy from a patient who we've already committed to. And so in my opinion, any triage system that's going to get buy-in from the healthcare workers and from public and from government is going to have to emphasize withholding access to treatment and de-emphasize withdrawing care. So what did we do? So we had the declaration of a public health emergency, and and we had immunity from the governor, but we did not have permission to triage. And so we did our best. We set up surgical review committees. We only had those 3 operating rooms open. And so there was a committee of people who was reviewing cases to make sure people were having equitable and fair access to those operating rooms. We did a ton of educating. There was a lot of misinformation around that immunity clause. People thought that meant that we could withhold care based on our clinical assessment and that we would be protected from that, but of course we weren't. So we spent a lot of time making sure people understood that we could not withhold care without the consent of a family. And because we didn't have a triage system, we maintained this first come, first serve model. And Beth Hockman, who I mentioned, and myself and a small group of other people acted as triage people. We distributed the beds as patients came in. And in the worst weeks, we would have between 30 and 40 new critically ill patients a day. And that's a lot an hour. So there's really no first come, first serve, right? So we would do our best to exercise judgment over who we thought would get the beds, and we really just did the best we could really. And though we never had permission to activate the triage teams, we had a triage system and committees on backup. And then the other really important thing that happened is that we began to understand that there were more than just the obvious stakeholders that were impacted by the surge and all of our individual triage decisions. So of course, the obvious one is our patients, right? Columbia is situated in Washington Heights, where our population is disproportionately made up of people of color, people living below the poverty line, people without health insurance. And the Washington Heights community made up the overwhelming majority of our admissions over the course of the surge. But there were some other things that turned out to be real competing interests. So I'm going to show, this is here, this is a graph showing the total ICU capacity in green and the surgical case volume in blue. And you could see right in the peak in the spring where the nadir is, where we had canceled all elective surgeries, of course, our surgical volume had gone down. And you can see it still hasn't really returned to normal. But that area above the curve there, those are patients who were denied an operation in the last year, right? So those are patients who were not emergency. They were cancer patients. They were heart failure patients. And we will have outcomes data starting to come out, right? We're a year into this. So, in the next couple of months, we can expect to see some outcomes data on those patients who had delayed access to care. And we'll start to better understand the impact of the cancellation and sort of the reprioritization of the hospital beds. And then, a stakeholder is Columbia's very identity and reputation as a quaternary care center, right? We are the place where tertiary care centers send their sickest patients. But because our beds were full, we couldn't accept transfers and we couldn't take, our normal referral patterns were all distorted. So for example, patients who needed heart transplants and liver transplants, we couldn't bring them in and we therefore couldn't start their transplant workup. And you can't be listed unless you're at our center. As I mentioned, our normal referral patterns were very distorted. So we have long-standing relationships with doctors at other, in other groups who send their patients to us. And when they couldn't send them to us, they would send them elsewhere. And you could imagine the cardiologists and the surgeons going bonkers because they were losing business to other hospitals. And that impacts the hospital's normal operating, in the long term, the hospital's normal operations. And so these are all really important stakeholders we need to be thinking about. So that brings us to today. This is I showed you the trend on the video. This is a more recent bed map. You can see that it is a lot less red, which is good news. But you will see that if you look at that stretch across the top, the ICU space, we're really full. And as I mentioned, the length of stay for COVID patients is long, but what we have found post-COVID is that the length of stay for non-COVID ICU patients is also really long compared to pre-COVID by the same diagnosis. And we think that's probably because patients who are admitted with heart failure, diabetes complications, things like that, have been without care for a year and so are therefore sicker now than they might have otherwise been. We have stopped making this bed map every day, but it looks like this all the time. And so what I want you to see here is that the ICU is full and we operate on a very fine margin of available space. And now there's less, the turnover is slower than it used to be. I can tell you that on a day that started just like this, I was overseeing the distribution of hospital beds. And in the course of 24 hours, I got 16 requests for ICU beds. And of those 16, easily a third of those patients you just knew they were never going to make it. But we don't have a triage system. We have a first come, first served system. And so we shuffled around and we put the patients in the ICU as the beds became available. And 3 of the patients that we put in the bed died within a few hours of being admitted to the ICU. And I would argue that we can do better than that. So what do we do now? I think the first thing that we need to do is to carefully look back and honestly have a discussion about the decisions that we made during the pandemic. We know that ICU strain leads to poorer outcomes, and that inconsistent approaches to allocation of resources leads to poorer outcomes. We have to measure what happened and we have to talk about it. This is both quantitative data and qualitative data. And we need to look at not just our own institution, but other institutions across the city and the state. Of course, this is really hard because we run the risk of losing public trust and, of course, opening up ourselves to medical legal liability. But I think it's really important. We need to continue to publish high quality data on outcomes of COVID patients so that super smart people like Carri can help us build algorithms to help reliably predict outcomes. We have to involve the community that we serve and understand their values, make them participants in the process. And finally, as a large urban academic medical center, we need to carefully define who our stakeholders are, to whom we have obligations, and we need to prioritize them in a way that allows us to apply consistent, data-driven decision-making to all patients who need access to care. Thank you.
Thank you both for an amazing presentation on both sides of this question. Before we jump into the Q&A, I want to say from the receiving end, I was back in the peak of the crisis. We were having bi-weekly meetings between sort of the leadership of the university, and we would get sort of the bi-weekly reports from everyone uptown and the superhuman effort that was actually taking place at our medical center, similar to other medical centers. And it is incredible how the system rallied to do incredible things. How resourceful it was. But as Katherine was saying, it's now time to actually look at what we did and try to sort of improve so that we don't have to necessarily improvise in the future, but we can actually have a sort of a better system in place to manage such incredible crisis. So I have a few questions to start us off, but I would like to invite people to also put questions in Q&A or chat. I will be monitoring both, and then I'll be sort of giving it to our 2 panelists. But I want to hear your thoughts on a very sort of rudimentary issue, and that is that there are many other industries where sort of data-driven decision-making, algorithmic decision-making has been sort of the way that we operate for decades now, certainly for the last 10, 15, 20 years. And somehow healthcare, even though there is abundance of data, is not one of these industries. Can we talk a little bit about that? What's the root cause? What are the opportunities? What are your thoughts about that? And I'm not putting you on the spot. It's not about sort of, it's just that, what can we be doing over there in order to actually improve decision-making and improve outcomes by using tools and ideas and techniques that seem to work in many, many other areas. Who wants to take that first?
I guess I'll start, and then Katherine, maybe you can provide the clinical perspective. So I think that there's one major hurdle that is starting to be broken down, has been access to detailed data. Traditionally, data in healthcare has been collected primarily for financial reimbursement purposes. And that's kind of the highest quality, the data that is available. And on top of that, most of the data systems are not very interoperable. So you could look into a hospital system, and before some of the stimulus high-tech funding that came in 15 years ago, within a single hospital, you would have multiple different electronic medical record systems and different units that didn't communicate with each other. And so you couldn't really get the type of data to utilize these tools. That has certainly changed dramatically in the last decade. The number of hospitals that now have electronic medical record systems are in the 80 to 90%. And now the number that have it across all the units is increasing quite a bit. So data is becoming more available. But I think that there's also kind of a cultural hesitation, and I'm sure Katherine can speak more specifically, just in my experiences, like speaking with clinicians about this fear of taking autonomy away from the clinician in making those decisions. And my perspective is never that these models or analytics are going to take over that, but it's to have this data to guide the decisions, because a computer can crunch through thousands, millions of data points where any individual provider will see, hundreds, right? And so to be able to complement that clinical judgment with the data, I think is really the future. And I think we're getting to kind of a regime change, but it's been a slow cultural change.
You said it very kindly. Doctors hate being told what to do, right? Like that's when you hear about it's not the science, it's the art of medicine, right? But so it's a real cultural problem. But I have to say that over, maybe the last decade or so, where we've really started to explore evidence-based medicine and evidence-based practices, we've also talked a lot about standardization. And there's a lot of, as you said, data coming out about standardized processes leading to better outcomes. We're getting better at the idea that we can follow a protocol. We can still be good doctors, and we could still have, gut feelings and sort of bend things. But that's a deeply cultural problem that we have. This idea that sort of we know better, but that as you say, with data and with seeing better outcomes, better efficiencies with standardized processes, we're starting to change that quite a bit.
So it's certainly the case that the first thing you do is you collect the data and you normalize it, you systematically make it available. So it's fantastic to hear that this is happening. I've heard the same story in a discussion that I believe, Carri, you were there when we were hearing from someone from Sloan Catering. And it's a similar idea about automating decisions. And the point that this individual was making was that the point is not to automate the jobs of the people at CUIMC or at Sloan Catering, but to use the data that we have, the experts that we have, to train our algorithms so that potentially we can improve outcomes and decisions in areas where we don't have the talent, we don't see the patient flow, so that maybe the doctors don't have the experience of seeing 20 or 50 cases a day in a particular area, but our algorithms have that availability. So maybe that's potentially another way of selling the algorithm, which I think actually will be useful, both in this country, but in other countries as well. Now, I want to pivot a little bit on the last comment that, Carri, you were making about your algorithm, the new algorithm that tries to maximize lives saved, and the comments that Katherine was making about how the public will react to an algorithm. If you were to describe to the public this algorithm, and they start imagining their way funneling through the decision tree, clearly there will be some people that will have, first of all, how do they understand that, and how do they perceive the value of such a system, and perhaps how do they internalize that, you know, not everyone is going to actually fare well when they go through a decision tree, which is something that you avoid by doing FIFO, right? Because in FIFO, first come, first serve, you essentially tie your hands and you say, I'm not going to make a decision. So where is the public in all of this? And have they even been told? You know, in some sense, do we have a dialogue with them in this area? Catherine?
Yeah, so I'll start. So I mean, I think your point is extremely important. What we need to start with honesty, and we need to start with looking back at what we did. And I think the overwhelming message to the public about the pandemic was one of great success, and it unquestionably was a success. But there were things that we did along the way. There were inconsistencies in treatment of care, treatment of patients. You know, I gave you the example of having 16 patients who needed access to beds and 3 people dying within an hour. I mean, it's, you know, we have to be open and honest about how things really look. And I think it's a safe time to do that now. But I think just at least starting to message the public that while, you know, the big picture was one of great success, that there was a lot of things along the way that could have potentially been done better. You know, we had, as you know, the main fear was of running out of ventilators, but that turned out not to be the case. But along the way, we tested at Columbia. We actually were one of the only hospitals to test dual ventilation, right? So having 2 patients on one machine, that's really a controversial idea. We need to bring that out, right? We need to have conversations. And I think it starts with messaging, and the messaging has to be free from fear, you know, of retribution from medical legal, you know, pursuits. But I think the only way to start this is by talking about what experiences were really like. And from there, we could start to talk about what a community's values are. You know, do healthcare workers get priority? Do women, do pregnant women, do children, you know, like what are the valid values of a community, and how do we build that into our algorithm? Because the public has to buy it in. But you're right, it's a hard pill to swallow, because, you know, an algorithm kind of essentially means somebody's going to lose, right? Somebody's going to get the bed and somebody isn't. But to be able to make that acceptable, people have to understand what it really looks like. And I think we haven't gone there yet.
Of course, somebody would lose the bed even with first come, first serve. It's just that somehow the perception is that this inefficient way of allocating the bed doesn't prioritize somebody else over me, right? At this point in time, Carri's research may be able to show that by doing something else, you may show up at random times and find the bed more often, because it's a much more efficient use of the resource. But you know, it's very tricky. And weaving in this sort of social consideration into the algorithm is difficult. And you know, I said before that other areas we have done incredibly well in algorithmic data-driven decision making, but we have not done well in that respect. And the field of algorithmic bias is huge, and is huge in other areas where, you know, you systematically automate decisions in a way that sort of, you know, once you know what you're doing, you realize that you don't want to necessarily be doing that. And we haven't figured out actually how to do that better. So that's an area maybe healthcare can leapfrog in ahead of online advertising, for example, and teach everybody else how to do that. Now, let me put one last thing on the table, and then I'm going to move on to questions that we're getting from our participants. But do you think that we are on the path of designing triage algorithms that will help us do these things in a somewhat more systematic, automated way? Is that something? Is that where we're going over the next 3, 5, 10 years, and perhaps in an accelerated pace because of what we experienced in the last 18 months, or not? What is the thought? I mean, Carri, you've been working on that, and you've been talking to a lot of the people in the hospital systems. Are they open to implementing such solutions, or?
Yeah, so I think that, again, it's like the way that the question is framed. And so I think there still seems to be trepidation regarding triage, because as we just discussed, someone always loses, right? And, there's acknowledgement that there's value in designing these things using data, and yet knowing that data is never perfect, that if you have limited representation from certain demographics and communities, that can result in biases in the recommendation. I have seen a lot more excitement and willingness, though, of how to make resource decisions using data. So like in the past year, the number of collaborators and projects that I've started that have come out about using data to make predictions of when demand is going to increase or where the demand is likely to be, and to make resource allocation decisions, how many beds to have, how many nurses to have, and when. There has been a lot more embracing of that than I would say when I first started working this area over 10 years ago, because I think there's this acknowledgement now, one, that data can be very useful to help guide these decisions, and also that kind of this, feeling your way through the dark is not the right thing to do, and that we can, especially in situations like a worldwide pandemic, the value of trying to be a little bit more thoughtful about these decisions can really be vast.
Great. I'm going to pivot to start asking other people's questions, and I'm going to start with a comment, but then I'll move to a specific question. The comment is from Deborah White, and it mostly says that this change in mindset, if we're going to affect the healthcare system, should probably start even by training in medical school. Which, switching topics and talking about the collaboration between business school and medical school, this is something that we're actively discussing. We're now discussing about bringing our students over there, but we're actually also discussing with Anil about bringing our faculty over there to sort of give specific short courses to the MD students, simply to provide background in some areas that may be useful. So this is something that we're trying to do. Now, there's a question for you, Katherine, about sort of this idea of withholding versus withdrawing, and sort of. Can you explain more about the ethics between sort of making these sort of distinction at the point, the time of the decision?
Yeah, well, so first of all, in just to a little context, in New York State, it is illegal to withhold or withdraw life-sustaining therapy without permission from the patient or the surrogate. So, just to lay that out there is sort of the context. But, just imagine being a practitioner and having, for example, a patient who's really sick in front of you. It is, the idea of not giving them or withholding ICU bed, for example, but perhaps putting them in a palliative care unit, introducing them to people who can help take care of them, to help, either, if they are already at the end of life and we're saying you're too sick for an ICU bed because you're not going to survive, withholding that ICU or critical care resources from that patient and sort of putting that patient in what we think is a better place for them, or a more clinically appropriate place for them, is hard perhaps, but it has a measure of comfort knowing that you're sort of doing the best you can. And withdrawing is a very different thing, right? So once we've committed resources to a patient, whether, you know, in whatever the circumstances are, but, you know, a patient, let's say, who is in the ICU, who's intubated, who has been sort of lingering for weeks, not really getting better, but not getting worse. And we saw that a lot with COVID patients, that they just sat for weeks and weeks and weeks. Taking the breathing tube, sedating the patient, taking the breathing tube out and watching them die is a very different thing than having treated them with care and compassion up front. And there's lots of analogies for, not just ICU care, but the idea of withholding versus withdrawing. It's just from the point of view of the practitioner, and of course the trauma to the patient and the family is significantly different. And so, wherever possible, we try to guide people into options of, not taking that next step, not escalating whenever we can. It's sort of about the moral distress to the care team and to the families. Very different. Those two things are very different.
There's a question about prioritization of making these decisions. And there is a good point that I actually forgot, that in the organ allocation area, which is an area that, I'm sure Katherine, you know a lot about, and Carri and I know a lot about, because a lot of our colleagues work on the market design questions in this particular area. There have been algorithms that operate in a different way than first come, first serve, in actually making them matching. Kidneys is a particular celebrated example that, over the last 15 years, there are a lot of algorithms. How is that being perceived by the public? Do they find them fair? Do they find them okay? Is that well received and without any complaints?
Yeah, you want me to start?
Yeah.
So I'll tell you something interesting that you probably didn't know. Originally, when we started doing kidney transplants back in like the 60s or so, out in University of Washington, or I'm sorry, dialysis out in University of Washington, there was a dialysis committee that would decide, because they only had 12 machines and dialysis took hours and hours and hours. So you could only take very few people. They formed a committee of people who would decide who was going to get access to those dialysis machines. And there was one doctor, there was a lawyer, there was a priest, and there was a housewife. And they were the ones who decided who would get access to care. But we've obviously evolved a lot since then. And so, when we have talked, organ transplantation is a perfect example of super scarce resources, right? Even more scarce than, for example, access to ICU beds. And so very quickly we formed the UNOS committee, who sort of laid out an algorithm basically similar to what Carri is working on as a triage system. You get points for certain things, and those points are designed to give the sickest patients the quickest access to organs. And that more or less has been well accepted by the public. It makes sense. There are instances where you could argue perhaps that, people who are sicker going into a transplant tend to have worse outcomes. And so we could actually shift and say, maybe we got to catch them just before they get really, really critically ill from their liver failure or something. But we haven't. We've built it with the system that the sickest people with the highest scores get access to those organs. But I have to say, there was a lot of other things that were involved, right? So, for example, we have also decided that we are ethically obliged to give patients livers, for example, who have liver failure from drinking, right? So we don't punish people and withhold organs. There's a lot of people on the transplant waiting list, but we don't punish people for sort of bad behavior, right? We have built that into our system, that we are blind from race, we are blind from ethnicity and religion, and we are blind from, your previous, behavior. And that's a well-designed system. The system is evolving a bit. UNOS updates their criteria every couple of years, sort of based on new data and also outcomes. We're sort of extending our donor pools in different ways. So things are sort of changing, but the basis of giving first organ to the sickest was decided years ago, and we've stuck with that.
Great. How about, there was a question about bed allocation more broadly. Is this done algorithmically in other areas of the hospital, not just the ICUs? I mean, or how is it done? Let me just ask that question. Carri, you're smiling, so you know something about that?
So the short answer is that there isn't really an algorithm. Or an official algorithm that is being used broadly across the board. There may be certain places that have more well-defined criteria. But when I started working on this work, a decade ago, I went to the Society of Critical Care, which is the professional society of ICU care, and looked up the official guidelines of how to make these decisions. And it was a 11-page document, and at the end it says, a lot of people want very clear guidelines. The original the main document is give it to the sickest people, and do the best that you can. And so at the last paragraph it says, a lot of people want kind of objective criteria. So here are some objective criteria. Here are some different measures for vital signs. And then it says at the bottom, but all of these are just kind of recommendations, and it is up to the clinical team to make their own assessment. And so that is in part why I started working in this area, realizing that there is a lot of variation and how clinicians make that decision. And it is not often guided by very extensive data-driven analysis. It may be some kind of more idiosyncratic based on what are the cases that individual has seen in the past and their own training. And so I think there's a lot of opportunity. This is certainly evolving. There are now a number of kind of data-driven early warning scores that provide alerts to guide these types of decisions, but again, it's not universally widespread in terms of their use, and so I think that it's evolving, but it's still a ways away.
Yeah. I'm thinking of the place where, let's say we go to a place where we're using this algorithmic decision making, and we had discussed before about how doctors feel, how nurses feel by having sort of some of their decision making power taken away from them, or the perception of that being taken away from them. The idea is that this is helping rather than taking away decision making capability, but is it, what's the perception about sort of the risks of that, sort of how it will impact the morale of people that work in these places? How will they feel about their own ability to actually influence outcomes rather than just blindly, like, you work in a factory, or do you sort of do something else that you have the ability to make important decisions yourself? Is that sort of part of the narrative, and where do people fall in that?
So moral distress is a serious problem. There's a lot of stuff. There's always been a lot of talk about moral distress and burnout, but we're seeing much more about it now than we were before. And I not surprisingly, COVID led to enormous amounts of moral distress and burnout, attrition of nurses, of physicians, early retirement. And of course, we can't fill those spots because people don't want. And then, of course, the increased strain, right? Because we don't have enough people around makes the job even harder. Moral distress is a really important problem, and it's very damaging. I would say that a lot of moral distress comes from caring for patients who, we used to call it, cases of futility, but really of non-beneficial care, right? So taking care of the same patient for days and weeks and months on end who are just wasting away and are never going to get better. we thrive on taking care of people and making them better, right? And so, for example, for ICU nurses, this idea of taking care of patients whose conditions are not reversible is really, really damaging. And so I think, whereas we talked about the moral distress about perhaps withholding and for sure withdrawing, there is a lot of moral distress with the situation that we have now. And I think, sort of qualitatively, people are very in favor of, somehow restricting access to care to patients that we know are not going to survive. I think Carri really hit the nail on the head when she talked about the problem of inconsistency. And so I think inconsistent decisions applied across the same hospital, for example, are also really damaging to nurses and physicians taking care of patients. We all want to advocate for our patients, but when we see people being treated differently, so I think just to sort of summarize, the idea of moral distress and the impact of healthcare workers of the current system and of a triage system is something that needs to be really carefully evaluated. I think that a system that worked better, that had better patient outcomes, would improve moral distress.
Okay. So I will pass it to Sorgata to close the event. But before that, I want to personally thank all of our attendees, and then, of course, thank Carri and Katherine for joining us today. This is both fascinating and important and ongoing. So we're looking forward to learning more about the work that you do. Sorgata, the floor is yours.
Thank you, Carri. Thank you, Katherine. Thank you, Costas. I'm blown away by the fact that the school is not shying away from difficult decision-making like this. And I'm also grateful that while Carri is doing brilliant work, making it really thorough and sophisticated predictive analytics, algorithm, and notification system, that Katherine is ultimately the one in control of patient outcomes. So there is definitely art and science here, and I appreciate and value your emphasis on ethics, because this is where this is, it really has like high importance and it matters a lot. So you're all welcome to come up to Boston. As I said, when we have the dean come, it's going to be a spectacle. So we hope you will all be able to attend, and we'd also love to have you both as speakers. And just for the folks out there in the Boston Alumni Association, Ben and I have plans to start doing in real life events. We don't think we'll have speaker events until 2022, but we are planning on a CAPE event at an alumnus's home, as well as a board member, Sophia Benar, will be hosting the jazz event, hopefully this year after a couple-year hiatus. So thanks everyone for coming. We look forward to seeing you in real life for the next event.
Thank you very much.